Hello, and welcome to the second session of Post-Pandemic, Driving Inclusive Growth in Asia, a seminar series co-sponsored by the Asian Bureau of Finance and Economic Research at the National University of Singapore, the Center for International Development at the Harvard Kennedy School, and the Lakshmi, Mittal, and Family South Asia Institute at Harvard University. I'm Salman Rafe, the Program Manager at the Mittal Institute, and on behalf of our organizers and panelists, I'd like to thank you all for joining us today. This event, titled Healthcare in Asia, Post-Pandemic, is one session in a three-part series. The final seminar will take place on March 16th at the same time as this one, 8:30 a.m. Eastern Time and 9:30 p.m. Singapore General Time. That session will be covering social economic policy. I encourage you all to join us there. You can register for those sessions through the same registration link in this seminar. You can find more information on the final session in the coming weeks, and we'll post links in the chat as well. I'd like to briefly introduce our panel before turning it over to them for the remainder of this session. Manoj Mohannan is an associate professor at the Stanford School of Public Policy at Duke University, with secondary appointments in the Department of Economics and the Duke Global Health Institute. Professor Mohannan is an applied microeconomist focusing on health and development economics with a background in medicine and public health. Sonia Balotra is professor of economics at the University of Warwick. Professor Balotra is an applied economist with research interests in skill creation, early childhood development, and health, including mental health, and her work seeks to understand the role of the family and of the legal and political environment. A large fraction of her work also has an emphasis on gender. Nachikit Moore is currently serving as a visiting scientist at the Banyan Academy of Leadership and Mental Health. An economist by training, Dr. Moore's current work is principally focused on the design of national and regional health systems. Among other work and affiliations, Dr. Moore also serves as commissioner on the Lancet Commission on Reimagining India's Health System. Finally, serving as our chair for today's panel, and as one of the three organizers of this series, is Dr. Tarun Khanna, faculty director of the Mittal Institute and the Jorge Paulo Leeuwen professor at the Harvard Business School. Dr. Khanna also serves as one of the co-chairs of the Lancet Commission. My thanks to all our panelists on behalf of everyone. Thank you for joining this session, and Tarun, I'll turn things over to you.
Okay, thank you, Salman. Good morning, good evening, good late evening, depending on where you are in the world. And a special thanks to Sonia for joining us from the beach in some Caribbean island, I presume, of which I'm very jealous because we have ice outside, outside my window in Boston right now. Anyway, it's a real pleasure to have you all. We've already done the introduction, so we won't spend too much time on it. I really would like to make a plug for the effort that Bernie Young, whose icon appears on the screen, encouraged us all to undertake some months ago, which is really two-pronged. One is that the COVID pandemic has, as we all know, shone a real light on pre-existing fissures in pretty much every society. And to my mind, I think those fissures were, of course, much more extreme in developing countries. And I think the exacerbation of those fissures has perhaps been even more extreme in developing countries. That's a hunch, awaiting empirical inquiry. And we thought it would be good to think about, of course, the pre-existing inequities in economic systems, in global economic systems, but also the extent to which, thinking a little bit optimistically, since I'm a glass half full kind of person, is there a way to reset the trajectories of these economies in some ways towards more inclusive growth? So there is sort of a very important policy issue, a little bit, how would I say it, idealistic maybe, but then that's what academics are supposed to do. We're supposed to imagine the possible and try to move things towards that. With that in mind, as Salman was introducing, Bernie and our third colleague, Asim Khwaja, who is an applied economist at the Harvard Kennedy School, and the three of us run these different institutions currently, ABFER, Center for International Development at Harvard, and the Mittal Institute, which is the current host of this program. We got together and said, let's at least kick things off with three panels. So that's what Salman was alluding to. The first one was on education a few weeks ago that Asim moderated. I drew the short straw for health today, which I'm really excited to do. And Bernie will lead one, a very interesting one, a few weeks from now on social cohesion. So I encourage you to participate in the conversation as much, or perhaps even more than, into individual panel discussions. So here's the format now. That's the end of the preambles. Actually, one more preamble. The Lancet Citizens Commission, to which Salman also alluded, is quite a crazy, ambitious effort led by my colleague Vikram Patel, who's a psychiatrist at Harvard Medical School, Gagandeep Kang, who is India's perhaps leading virologist, perhaps one of the leading virologists in the world at CMC Vellore in South India, scientist by training. Kiran Mazumdar, who is India's iconic biotech entrepreneur, and by myself. And what I would direct your attention to, since it's relevant to the panels, these three panels, is the word citizens in the title of the commission, the Lancet Citizens Commission for Reimagining India's Healthcare. And I think there's something very special about that focus, which is to say that we want to encourage the citizenry to participate, not just the policymakers sitting in their proverbial ivory towers trying to do something in ways that clearly in the case of India has not worked in several decades in terms of moving us towards our ideal of universal healthcare of some sort. So I'd encourage you to visit the Citizens Healthcare site and get involved. There are literally dozens of organizations involved, hundreds of researchers, and it's emerging as a platform for health discussions, at least in one major Indian economy, India. So Man, if you could put the link to the Lancet Commission in the chat, that would be good for everybody. So without further ado, in the following order, Manoj, Sonia, and then Nachiket, each will make about 7 minutes of comments to introduce us to the broad spectrum of their research. Manoj is generally going to speak about the very low quality of healthcare in India in particular. Sonia is going to introduce us to a range of issues, as I understand, including, to my mind, what is really interesting, sad but interesting, is the unfortunate reality of very poor mental health in South Asia, and particularly in Pakistan, based on her recent excellent study there. And Nachiket, who to me is the resident guru of health finance in India, will shine a light on some really tough to address problems that he and his band of merry men and women and I have been struggling with for the last, in my case, 18 months, in his case, for a decade or more. So Manoj, over to you, and I'll ask for indulgence because I will be rude starting in about 7 minutes, and my rudeness will increase monotonically with the extent of your departure from 7 minutes. So Manoj, over to you, and thank you.
Thank you so much, Tarun and Bernie, for having us on this panel, and it's wonderful to join Sonia and Nachiket, both old friends, and it's great to think through this critical issue of inclusive growth and the patterns we've seen in the past. I would also fully endorse and encourage you to increase your interruptions exponentially, not just monotonically. If I cross the 7 minute mark, I'm keeping my eye on the line. Okay. So let me start with some overall work. As you just said, my overall work in the last 15 years or so has looked at broadly topics related to quality and performance, specific in the healthcare sector. And much of this work and my comments in the next several minutes, I will sort of string together what we've learned from about 4 papers, 3 or 4 research projects. But I do want to bring it back to this question of inclusive growth. And the way I'm going to think about that is much of the healthcare quality in India, but also globally, is characterized by a huge amount of variance. There's even in India, and I'm going to be taking lots of pot shots at poor quality of care, but it's worthwhile pointing out that there are islands of fantastic care even in India. So much so that India is also one of the destinations for a global medical tourism industry, where people from all over the world are now slowly coming in to incredibly good hospitals, well-run health centers that provide care for those who can afford to pay for it. Right? So it's when we think about the quality of care, I will be talking about the bottom end of the distribution, but it's also important to remember that there are possibly alternative solutions by making care available at the higher end of the distribution accessible to others as well. And I think Nachiket would be much better equipped to talk about some of those issues. My own interest in this topic around quality came from one of my first studies we were doing, looking at this, at that time, a very popular program in the state of Gujarat called Chiranjeevi Yojana. And Chiranjeevi sort of was a groundbreaking program at the time. This was in the early 2010s, but early 2000s even, where they wanted to introduce a program where the government would provide coverage for women from below poverty line households, like really, really poor women, to be able to go to private sector doctors and deliver their babies there. The reason why they did that was because the state, this is about a state of over 50, 60 million. I see there's a question up there. Did you have a, Tarun, you're muted.
Oh,
A hand up from ABFER?
I think we can ignore. Yeah.
Okay.
Let's just
I'll go ahead. So this program was essentially trying to make care available to a wide number of women who were poorer. The problem, however, was when we went back and collected all this data and looked at the evidence, it looked like it had increased availability of care, but had not made any difference to outcomes. And we tried to understand why that was. Is despite all the claims, there was no change in the actual take-up of the program relative to whatever was happening earlier, that is take-up of care provided, or the actual outcomes, maternal deaths, child deaths, and so on and so forth. And one culprit that seemed to come up continuously was around quality, poor quality. You can deliver more, but if the more that you're delivering is still the same quality, low quality of care, it's not really going to help anyone. You might spend a lot of money, but it doesn't really change the outcome. And so that set up the stage for us to do a whole bunch of studies, working with Jishnu Das, who is now at Georgetown, and I, as well as colleagues from that group. We did a number of studies around standardized patients. And the idea was, well, it's really hard to measure quality because this is something that's happening in a doctor's office. And monitoring the doctors is hard. So then we developed trained actors who would go in and present a case, sometimes as simple as having a child with diarrhea at home and asking for what should I do. And the surprising thing we found from those studies was the quality was stunningly low, but stunningly low on two dimensions. One is they weren't doing the right things, that is giving something as simple as oral rehydration solutions, right? That's something that we've known for decades can improve outcomes for something like childhood diarrhea. Richard Cash and others have spent many, many decades trying to inform the global public that it's effective. These guys know it, but they don't do it. And the second dimension is the overuse of antibiotics and steroids in such an indiscriminate manner, it was actually stunning. So in a second set of papers, we tried to describe what was called the no-do gap. Like, maybe it was that these people genuinely misdiagnosed these cases. Is that possible? So we went back and we first did interviews with them, sitting down in an interview setting and said, hey, doc, if so-and-so patient shows up to your clinic, what would you do? And then a few weeks or months later, we send in these trained actors. And what we find is this massive gap. For example, for this diarrhea thing I mentioned, if about 70% of providers would report that they will give you an ORS when you walk into their clinic, in practice, only about 17% of them actually do. And then you contrast that with how many of them give you unnecessary medications, it was equally stunning. So that sort of set the stage for saying, maybe there is something broken in the system. It's about accountability. It's about incentives. We don't have time. I'm keeping my eye on the clock. But the short summary from all of this is, when we introduce interventions to ensure or promote guideline adherence, you do see some positive effects, right? I started all of this with the notion that there's a low level of adherence to guidelines. Well, you can possibly do that if you introduce very clear incentives tied to specific adherence to guidelines. But doing that for the entire system is really, really hard. And one of our more creative papers where we tried to incentivize performance or contracts that are tied to patient outcomes versus adherence to inputs, we find, broadly speaking, both can work, but they work in very different settings. And the key idea is, if you're a high-powered individual with high levels of human capital, then giving them the freedom to innovate and freedom to decide how to improve their performance tied to a patient outcome is probably more important. But then once COVID comes along, some of these things change, and I'll wait to discuss at length with the panel. So let me stop my comments here and turn it over to Sonia.
So Manoj, is it a fair conclusion to say, based on what you were saying, that in the case of these physicians mistreating diarrhea, for instance, in that example, that it's not a question of knowledge or training as much as it is about the incentives? That's a good good summary of that, right?
I think so. And that's what we are finding even in ongoing work that we are doing right now is people know, but they don't continue to adhere to what they know even. So that's the challenge.
Okay, great. So we'll come back to the post-COVID stuff later on, but let's cycle through. But thank you for staying on time. Sonia, all yours. You want to share a screen? Yeah. You're on mute, Sonia. Yeah.
Hi, thank you for inviting me. So should I begin, Tarun?
Yes, please do. Please do.
Okay. Well, thanks for inviting me. I have slides and they probably are too many, so I'll just stop in 7 minutes wherever I am. I just want to highlight a few issues, and then of course we have time after these 7 minutes to discuss them and to talk about the context of India and also any changes during the pandemic. So my research has focused in a sense on making a case for investing in women's health, the case for early life health investments, and recently I've been doing some work on implementation challenges with universal health coverage. So the case for investing in women, the magnitude of perinatal depression and domestic violence, both approximating 1 in 3, is I think hardly known. So I just put up the numbers here. I feel I have sort of focused in on 4 dimensions of neglect, which are maternal depression, domestic violence, maternal mortality, and the selective abortion of girls. And what these 4 sorts of public health issues have in common is that they're underreported, undertreated, and insufficiently understood. So we need surveillance and to create evidence and monitor progress. Absent data is a major hindrance to both research and policy. Here in one slide, very briefly, I'm attempting to provide some of that evidence that's possibly relevant to policy. In each case, it's only one solution that the research I've been involved in suggests might work. There are, of course, other solutions. So in collaboration with my co-authors named here, Victoria, Pietro, and Asha, and others, it's a big team, we ran a randomized controlled trial in rural Pakistan, which involved delivering psychotherapy through community health workers to women diagnosed as depressed in pregnancy. The intervention started in the 3rd trimester of pregnancy and continued till the children were 10 months old. And in that time, in the 10 months, the woman received 16 home visits from a lightly trained lady health worker. I think an upshot of that study for more general consideration is that one could integrate maternal depression screening and support with primary care. In fact, I don't say it here, but I would also like to advocate to integrate domestic violence screening and support with primary care. We have these trained community health workers who get to know the women, earn their confidence, are in and out of their houses, for example, providing immunization. And it makes just so much sense financially and in terms of the trust that the woman has with this community health worker to refurbish their role to include identification of cases of depression or domestic violence and basic support services. In other research I did on domestic violence, surveying the literature and the different sort of randomized trials in the field, I think it's fair to say that a lot of research has focused on empowering women by giving them skills or cash or training or even jobs. And the results are quite mixed. And the reason is that where women have an exit option, then empowerment can help, but often they don't because of stigma or legal barriers or financial reliance on men. And in those cases, empowering women in those ways that we're familiar with can actually cause male backlash and worsen the problem. So just to keep it brief and to be able to say something that's possibly positive and useful, keeping men in jobs seems to mitigate domestic violence. One reason is that it reduces stress. Well, certainly being thrown out of a job creates a lot of stress because there's income stress, but also because of identity stress. And then having men idle tends to lead, there's evidence from across the world, including rich and poor countries, that idle men are prone to substance abuse and they kind of have too much time on their hands. So keeping men in jobs helps through all of these different mechanisms. And in this work that was using administrative data, combining court data, employment data, and welfare registers, we investigate in detail the mechanisms and the role of unemployment benefits. The third harm to women, maternal mortality, is similar to the first two in the sense that it's not properly recorded, it's not systematically monitored, and we don't actually see we haven't actually seen maternal mortality fall to achievable levels. In other words, it's fallen, but it's fallen short of its Millennium Development Goal. The Sustainable Development Goal is far more ambitious, and we really need to double down in order to achieve it. Unlike some of the other problems listed on this slide, we actually do know what works for maternal mortality. Simple extension of reproductive health coverage, including skilled attendance at delivery, what Manoj mentioned, and prenatal care on their own can make a lot of difference. In research where we leverage the passage, the sort of idiosyncratic timing of the passage of gender quotas for women in parliament across 21 low and middle income countries, we find that there's a sharp and sustained drop in maternal mortality rates very soon after the share of women in government is jumped up through a quota. We then repeated that whole exercise using completely different data and a different law, which is the Indian village quota law. So we did this for countries, and then we did it for the states of India. Even the actual magnitude is similar. And you find that as soon as women are in the policy-making seat, then this otherwise neglected concern becomes part of an effective agenda. And the last issue on the slide, this is possibly the hardest to change because it's parents, like domestic violence. It's not something we choose. Depression is something we fall into. But the abortion of girls is a choice that parents make. And it's really the most stark statement of son preference because it is killing and you do it to your own child. So it's very difficult for any outside intervention to change preferences of families within families. We find that reform to property law, we use the West Bengal tenancy reform. That was a major reform to property law that gave tenants inheritance rights. That exacerbated son preference because those tenancy rights were heritable. And then we looked at inheritance law reform, which basically gave women equal rights to men in inheritance. And we showed in different research papers that both of these misfire. They exacerbate son preference. And that's because the legal reform happened in these two cases at a time when the social norm was not ready to adapt to it. Instead, we find that leadership matters, rather like with maternal mortality, and having Muslims rather than Hindu legislators leads to significant differences in the rate of sex-selective abortion. It's quite a complex issue, and the paper looks carefully at son preference versus the religious aberrance of abortion. So Muslims, similar to Christians, don't like abortion, just like they don't like contraception. They actually have similar rates of son preference as reported in the DHS surveys. Tarun, I'm happy for you to stop me when I must stop.
Sonia, why don't you say, do you want to say what that chart is and then wrap up and then we'll pick up later?
Okay. Maybe what I can do is say, like, I'll take 1 minute. I won't speak much, but I'll flag stuff so that we can then talk about it. So the case for investing in children is that there are higher returns. It seems that if you intervene on improving infant health, it results causally in better school performance, better earnings, and a lower risk of chronic disease in adulthood. And if you recognized this potential, you would have a investment with much higher returns. Presumably, you would do more of it. And universal health coverage, there are weak links in the chain. And there's some work I've done recently on health systems restructuring. I haven't done any work on this, but I think it's very important to consider how to replace the current patent system, which creates markups. And I'll stop here.
Okay. Sonia, thank you very much. I mean, there's so much that you said I'd love to pick up on, and it connects to the quality issue also I think in terms of contracts and implicit contracts and non-measurability and non-observability and things like that. So at the abstract level, they're all connected. But two things in particular that I'd love for us to pick up in the conversation later on. One is about the role of community health workers, which you alluded to, in particular, an expanded role potentially. And of course, we're seeing that across societies in so many different ways, that if you develop trust with the patient somehow, and when that trust is broken, then all sorts of pathologies ensue. And the second is something that you mentioned in the context of the domestic violence work, which has to do with intra-family bargaining power, in particular with the extent to which the woman is actually empowered to, as you put it, have an exit option, and not just other aspects of the choice set that are available to her. And I'm recalling some lovely work that Nava Ashraf, my former colleague, who you may know at the LSE now, has done on this. So maybe we can pick that up. But thank you very much for a nice overview. Nachiket, over to you.
Thank you, Tarun. I'm going to stick to the whole finance situation as was, asked of me. You've heard two lovely presentations already of deep insights as to what's happening kind of closer to the ground. I'm going to go a little bit, at a higher level to try and ask the question, given all of this, how are governments responding to this? Now, we know already, and it's something that you've heard from the two speakers, that while the Indian situation is much improved from when we gained our independence in 1947, life expectancy, for example, is double what it was when we exited the British Raj. The situation is well below par when it's compared even to poorer countries in our neighborhood, Bangladesh, Sri Lanka, Nepal, and certainly around the world. Our global ranking is really quite abysmal. But for a variety of reasons, our governments, both central and state, continue to be under the thrall of the older commanding heights of the public sector thinking, and what I would call somewhat simplistic, Keynesian ideas about what it takes to generate growth, with no real discussion about central issues relating to failures of markets and the role of governments. What this does is, if you see budget after budget, government after government in the states and the center, they continue to direct investment towards sectors in which there's already adequate capacity. For example, rural roads. India is a global leader in rural road capacity thanks to the work of the some of the earlier governments in terms of per square kilometer density, second only to France now. Or in other sectors such as agriculture, infrastructure, financial services, the markets have been well positioned to take over for a while now. The logic of the commanding heights was that the markets are not ready. But the governments continue to direct investment there to the complete neglect of sectors like healthcare. In fact, we know already that sectors like healthcare suffer from serious market failures. And all countries, whatever limited research I've done, suggests that with successful health systems, recognizing this serious market failure, and this includes what I would call rabid market economies like Japan, Switzerland, Germany, recognize that there is a serious market failure in healthcare. And also the fact that health is both a crucial input for growth, but also a critical output of growth. So in some ways, instead of waiting for growth to happen to get health, they recognize that maybe attempting to give good health outcomes to people might be a shorter route to get one of the key reasons you want growth. They have directed upwards of 70 to 75% of total health expenditure from tax resources towards healthcare, and have very tightly controlled the behavior of both providers and consumers. Against that, our state governments are directing 30% to 50% of total health expenditures towards growth. A neighbor of ours, Thailand, has a tax to GDP ratio that's comparable to India, around 17, 18%. But against India's 5% of its annual budget, Thailand invests 15% of its annual budget in healthcare and has an out-of-pocket expenditure ratio of, which is one of the lowest in the world, of close to 10%. Now, these are not new facts. They're well known to our governments, but it has not produced any change in the investment strategies, even post the devastating impact that the pandemic has had. In fact, it is clear from both time series as well as cross-sectional data that as states have gotten richer, they have on average reduced their contribution towards healthcare sector as a proportion of their state domestic product. And as a result, not only have out-of-pocket expenditures remained high, with all of the attendant impact on financial catastrophe and poor health outcomes, but in the absence of any form of control, a free market ethic has gradually become more and more the dominant narrative in health systems in India. With this ethic, which I think is the real problem, the worry is that if the governments were to even now come up with 3 times more money, it may not generate the health outcomes that we need or the health systems that we want. We already see this in some of the more developed southern states, where all increased spending has gone towards increased C-sections, increased, some states as high as 60%, and not produce the kind of reductions in maternal mortality and mental health outcomes that we need. The solution, at least the way I think about it, is, if we want to think about where do we go from here, is to stop focusing just on one actor, which is the government, and saying, because so far the narrative has been, give us more money from the budget. Now, I'm not saying that narrative is not important. It is critical, as I've said earlier. But to actually broaden that perspective, to look at multiple aspects of the health system. How are the insurance markets regulated? Why can we not improve value added from out-of-pocket expenditures, which is the dominant form of financing? What about the performance of the public sector? What can we learn from the world about how to get the public sector to perform and to address some of the many challenges that Manoj pointed out? And what about the corporate health sector? What is it doing? It has an under 5% market share in the overall health system. And the belief is that this change process that we need, which is multidimensional, can't begin at the policy level, but actually has to begin even deeper at the level of mental models that inform these policies. In some of the work that we are doing, including for the Lancet Commission, we're attempting to identify these flawed mental models and have begun an exploration about how we might go about altering. Because the view is that if you keep hitting at the policy level without addressing the core beliefs that inform those policies, we're not going to get much of a result. So I'll stop here, Tarun. I'm certainly happy to go on, but maybe,
Oh, that's great. That's great, Nachikeet. It's a perfect overview. I'd focus people's attentions on over-reliance on the free market ethic as a construct, and this rather ambitious but very important goal of saying, is there some way in which we can address the mental models on the basis of which, in this view, poor policy choices continue to be made? Because if we don't, then continue to funnel money into a system that doesn't work will simply exacerbate the existing problems. Manoj, I wonder if you, so what I'm going to do is just moderate a little bit of a conversation, and I'd encourage all the panelists to jump in, since there's only 3 of you and me, just 4 of us. Let's have a conversation for a few minutes, and then Salman is going to feed me a bunch of questions. To the audience, please do type questions into the into the chat, and they'll make their way to me. There was some gentleman who was asking the moderator to slow down. Sir, I'm not sure whether you want me to speak slower or you want me to ask the panelists to speak more.
I think he was referring to the original introduction.
Okay. Oh, the original long preamble. Okay.
No,
yes.
Not by you, by I think Salman.
Okay. Never mind. But let's have a conversation now. Is this the spirit of what we'd like? So Manoj, this last point that Nachiket said, just to pick up on one concrete thing, that C-section rates. Nachiket, I think it's Kerala, right? That you sometimes allude to. Is that?
I mean, it's Kerala, it's Jammu and Kashmir, it's Telangana, it's Andhra Pradesh, it's Tamil Nadu. And within poorer states, it's districts. So overall does poorly, but Lucknow is crazy.
So this seems to tie into that paper on that you were alluding to briefly in your comments on incentive effects and trying to do sort of what in a simple principal agent model might suggest would be the right contract, and then you see odd outcomes or pathological outcomes. Do you want to comment on this or elaborate?
Absolutely, and thanks Nachiket for mentioning this. This is the C-section phenomenon that you mentioned about growth in C-sections is pretty rampant, and it's happened everywhere. But in India, it also takes on an additional, more pernicious outcome, because in addition to C-sections, we see similar things happening with hysterectomies. So when initially some of these cooperative insurance schemes were introduced, entire populations of women under 35 would start losing their uteruses because hysterectomies were very well compensated under the program. And that's the kind of, it's very clearly an instance of supplier-induced demand there. And the problem then is, if you take it, my own view, and Nachiket, tell me if this is the wrong way to think about what you were just telling us about the mental models. In some sense, the push we are making now is for governments to start taking on the stewardship role in healthcare much more seriously. And they continue to, despite decades, they continue to push on with this model of wanting to deliver care. And so separating that out and going back to the stewardship function would mean they need to understand, A, what is the outcome they really want? And I know it's easy to sort of throw rocks at the government's house, but it's a hard question. When we say, do you want a healthier population? The answer is always resoundingly yes. But what do we really mean by that? Is it contractable? Is it observable, verifiable? Those are challenges. And so when they don't have that, they often then turn to procedures and make their programs, whether it's insurance system or delivery, tied to X number of procedures. And solving that will be, I think, the hardest problem for them, because otherwise, all we have is a system where we say, yes, C-sections and hysterectomies are covered under the program, but we have a very robust system that will ensure that every patient's procedure is performed appropriately, and there's a way of checks and balances that can audit these cases and hold them to account, which I think countries like India are not quite yet ready for, but perhaps I'm wrong.
I mean, the whole C-section issue is something I study somewhat, and I'm hoping to do more in-depth work in it. I mean, one factoid that I think we need to keep in mind, that it's not just the private sector.
Right.
In many districts in the South and in Jammu and Kashmir and in Punjab, the government does more C-sections than the private sector does, and sometimes by a big margin. Second, we have this belief that government is pro-poor and pro-rural. That's not borne out by the data. The data suggests that if you took out the private sector from rural areas, you'd get a tripling of maternal mortality.
Yeah.
It's really the private sector that's holding the fort in rural areas, and the government is very urban focused.
Yeah. So
if you see Shravasti versus Lucknow, government does 25% C-sections in Lucknow and close to 1.5% in Shravasti. Right? So, and it's really the 10% that the private sector does that brings the number up for Shravasti. Otherwise, you would get a complete disaster in that area. So it's not, that's why I use this kind of catch-all phrase of a free market culture. Because I also have this anxiety that a state like Bihar is spending 500 rupees per capita on healthcare from government money. Some of the southern states, like Kerala, for example, are spending 5 times more per capita. Yet they are not able to claim they have UHC capability. Why is that? Because their cost structures are not that different. Remember, Kerala is a rich economy in a poor country. So it has the same benefit that the UK NHS has, that the US system has. It sucks in doctors, nurses from wherever they are available because it's able to pay them more. It doesn't look like migration because it's the same country. But, so it's a little bit more complex than that is my sense. Now, one mental model, just to stay with the mental model analogy that it needs a lot of debate. I don't know if it's the right mental model, but from a straw man perspective, the world has gone. There are, other than I think Cuba and Sri Lanka, there are no good health systems that are an exception now, not even Vietnam, has gone towards what we call a purchaser-provider split, in which the ministries and departments of health no longer get allocated budgets automatically. They are treated like independent public sector units providing healthcare. Another government department. In Thailand, it's called the National Health Security Office. In Turkey, it's called SSO. In the UK, it's called the NHS Trust. They receive the money and they pay the government as a provider. It's called the internal market. Mrs. Thatcher came up with it. I'm sure others came up with it, but she was the politician behind it. Forces performance of some sort. Now, we have to be careful. What is that sort of performance? Thailand has done the best job of that. Israel has done the best job of that. Of what do you mean by performance? That's something India may need to think about in order to, because the old Semashko thinking doesn't seem to be working, as your own evidence points out.
So, Sonia, do you want to? This is your sandbox of between. Not that I want to focus only on C-sections or hysterectomies or other such things, but you think a lot about maternal health in particular. Do you want to comment on this or come in on this discussion?
Maybe one observation I can make is that I've analyzed the health data for Brazil quite comprehensively. Also their policies, which are, I think, quite instructive for South Asia. And notice that when, like to make it brief, when things were improving in general, the one thing that wasn't, so in general, vital stats indicated improvements in maternal and infant mortality. There was a lot of outreach, fertility was falling. There were surveys where people expressed greater satisfaction with health. But along with this tide of good things, C-section rates were going up. And I did wonder if it was supply-induced or demand-induced. I don't know. There was no way I could identify. But I just wonder, just to raise the question, whether it might also be demand based on misinformation. I think that there really isn't enough information for women on what choice they should make with regard to C-sections. The other sort of remark I'd make based on reading, not on research, is that in Europe, often C-sections are overdone, not because of financial incentives or information, but just for scheduling convenience. It's easier for one or the other party to timetable the birth.
Okay. Can I ask a quick follow-up question? Sonia has done work on female infanticide. And I'm thinking specifically, Sonia, your work on that looks at the availability of technology and how that changes these procedures. In some sense, does that sort of indicate or suggest that there is actually a lot of play in this? There's a lot of space on this topic to try and intervene to mitigate some of the consequences of supplier-induced demand, knowing that whether it's through insurance systems or the kinds of reforms we are thinking about, or through technology, there is likelihood that some of these procedures will be driven by the providers.
Yeah, with sex-selective abortion, I think there's a lot of evidence in papers that have been written by non-economists like anthropologists I remember a Guardian piece in the UK, a UK newspaper piece that involved an individual from, I think a journalist, from England going to India and pretending to need a scan at a time when these scans were, when sex detection with an ultrasound scan was prohibited, just to see if the prohibition would apply. And it absolutely didn't apply. She went through several clinics. So sorry, it's a digression, but what I want to say is I think in that particular domain, there's evidence of this being a business. It's quite quick and easy to do an ultrasound scan, and it should not be so quick and easy, but it can, when done the dirty way, to do an abortion. So there's a lot of, there are a lot of half-baked practitioners who are offering both the scan and then the more sensitive procedure of the abortion, and it is harming women's health. So unsafe abortion is one of the top 4 causes of maternal death. So what drew my attention to that sort of statistic was not so much the Indian case, although it does apply, it's just I didn't have data on it, but the broader case of funding for reproductive health, overseas aid for reproductive health, being quite reliant on America. America provides a large share of it, and it cycles with the color of the presidential party. So with every Republican, the global gag rule is enforced, and with every Democrat, it's repealed. And there are these swings in overseas aid for maternal health and family planning. And when the Republicans are in power, this actually means the clinics that were open close, and people had a sort of culture of, for example, how much they use contraception, and then there's a sudden shock driven by something completely outside, like who won the US election. And they have, in fact, unexpected conceptions, because when the, sorry, I'm rambling now, I'll stop soon. But when the clinics that provide abortion services are closed because of the pro-life agenda in America, then those same clinics were also providing contraception. And so there's then a scarcity of safe abortion facilities, but also difficulty accessing contraception. And so that policy has misfired, because women then are more likely to conceive. And there's an increase in demand for abortion. So on balance, there's an increase in unsafe abortions and maternal death.
So you're drawing attention to a really interesting, thing that's maybe a little bit away from the main focus of the panel, but is important, which is political cycles can influence cycles of allocation to health. Of course, a dismal reality in India is that no government seems to put any primacy on health, which is just continues to be, in my role at the Lancet Commission, one of the things that has come up numerous times is, how come in an electoral democracy, health is just not a voting issue? It just isn't. And that's just really interesting, whereas education has become more of a voting issue. I don't want to, go ahead. Do you want to say something, Sonia? And then
I think that's really important. And I think some grassroots work, which we're very good at in India, could actually increase awareness and demand for health. So, often less educated people think that items like infant mortality are sort of God-given.
Sonia, you're cutting out. I think you're moving around, so maybe your Wi-Fi. Okay, let me
Sorry,
come back.
I'm moving to plug in my laptop.
Okay, no problem. But we were losing you for a second. Okay, what I heard Sonia say was that her view is that there is room to make health an electoral issue by some grassroots education mobilization. From your lips to the ears of God or whoever your desired policymaker is. Let me just highlight a comment that our co-organizer Bernie Young put in the chat, which is he's sort of very dismayed, and I think his depression levels are going up listening to all of you, which is he's saying that not only are there social structures in place that seem to systemically and systematically militate against good health outcomes, We talked about lack of meaningful power to the women in many societies, as an example, or religious strictures that might go one way or the other, or political cycles. But we also have not just inefficient government outcomes, but even regressive distribution. Apropos what Nachiket was just saying, with the government in India being not pro-poor and poor rural, which is the way it would like to think of itself, I think, in most instances. And so he says, is this common in many countries, in low-income countries? And has this been made worse by COVID? So I wonder if any panelist wants to pick up on this.
I mean, my understanding, Tarun, is that the other big country in Africa is Nigeria. And they are as bad as we are. But Bangladesh is doing much better. It spends a fraction of what we spend. In fact, in our neighborhood, only Pakistan is doing as badly or worse. Nepal has built one of the best primary care systems that I'm aware of, integrated mental health services, integrated number of other services into their primary care structure. Sri Lanka has had a record of high performance for a really long time. Now it's creaking under the weight of NCDs and other things, because it's, relative to some of the benchmarks that other poor nations set, it's not hard to look good. But now when you start to get to a certain level of performance, it becomes harder and harder. But I wouldn't say by any Rwanda, 98% coverage of primary care. They stopped building hospitals. And their use of technology, the Babylon type tools, is at the modern cutting edge. Not what we call telemedicine, which is nothing but a doctor at the end of the phone doing the same old stuff that he was doing 50 years ago, but a true blue modern AI and NLP system, Rwanda. So I wouldn't say the story is really all that bad. And of course, I've been studying One Health work in Kenya. Again, a stellar example of how to go about thinking about One Health issue. We don't even get into that here, but very good example of what they did with their zoonotic disease unit.
So I would just add that, if you could Kenya is I'm very familiar with East Africa, and, Rwanda, you could even sort of quote unquote dismiss as a special case because of its technocratic government, small size, this, that, and the other, many things that you could list. But Kenya is a polarized, fractious society with so many tribes, so many fissures, so many gender issues. And so I suppose you could see this as a happy story, that even in that really, really unsalubrious environment, something has, there is an intervention that makes a meaningful difference. Sorry, Manoj, you look like you were going to say something.
I was just going to build on that, also take on, Bernie points out this question about, how has COVID affected all of this? And if you can indulge, I would like to sort of go on to that part a little bit as well. As I think this issue around alignment of incentives, it's not just in India, this is global, right? It happens even in the US, where we see that the system rewards more tests and more tests are what we get. And that's fairly common across the board. The thing that we see that has changed during COVID is two sets of things. One is there was a lot that happened in the realm of trust. And I think both Nachiket and Sonia had mentioned around the issues around trust. People lost trust very quickly. And part of it was because our inability to communicate science well and in a way that it reaches both the providers who are hopefully more technically trained and aware, as well as the general public. The net result was a combination of confusing guidelines that COVID brought along that were changing frequently, which is not a bad thing because that's what science is supposed to do. But the harder part was our providers in many countries, even in the US, there are small fringe elements that continue to prescribe and promote drugs like ivermectin, even now. Hydrochloroquine wasn't on the official India's treatment guidelines until 6 months ago. And so those kinds of problems set up a very complicated environment. And the second part is how things were made worse is, at least I can only say this in a handful of countries that I'm aware of, the average provider does not spend time learning what's new in the field. You're practicing medicine based on what you learned 20 or so years ago. And without that practice, you're often adopting new guidelines based on what is hearsay rather than learning from primary literature. And so the Ministry of Health puts out a new guideline saying ivermectin is good for COVID. Before you know it, the whole country has to go through a cycle of everyone prescribing ivermectin and hydrochloroquine before these things are improved. And that creates a huge amount of wastage, but also inappropriate care. There's financial and health aspects. And so going back to your question of inclusive growth, the rich people in India might be able to afford unnecessary antibiotics, hospitalizations, and tests, and then get over it. But it's the poor who've now suffered financially as well, and the consequences can be fairly large, and it'll take a while for us to get out of. I don't know if there is a positive impact. I think all of us are still scratching our heads about how to change the culture of primary care, evidence-based care in these settings. Tarun, you know, our colleague Sachet Balsari at Harvard and I have been also trying to, see how we can do this better to improve evidence-based care. And it fits into what Nachiket was saying is maybe it's not just a private sector, it's both private and public, but it needs to change the culture of care, and that's going to be hard.
This goes back, Nachiket, you want to just say, maybe 2-3 minutes worth of more about your mental models idea and the work that your group has been doing, because it relates to this culture of care. And effectively, Manoj is making a pitch for your way of talking without using the word mental models. But
I mean, the one mental model, just to stay with this issue, is that the government believes it operates with complete contracts. It can fully observe all behavior of all providers down to the last one. We know that even in a corporate setting with all of the modern data systems, this notion of complete contracts and full observability is false. Right? We need to get them out of that thinking and to recognize that this line item budgeting with 1,800 line items that tell people, how many, syringes to buy and how many gloves to buy and all of that is not going to produce the outcomes they need. Right now, whether you call it a markets, internal markets, nothing to do with the private sector. It's an internal conversation, or you delegate more authority, or there are many tools of doing this. And it's a shift in mental model, which I think creates a great deal of discomfort amongst governments. And this is not just Bihar, right? This is Kerala, Tamil Nadu, Andhra Pradesh, everybody is following this notion of complete contracts, which needs to be revisited. And that's a core mental model issue, because without that, I don't think we're going to get any of the outcomes that we are hoping to get. Why would somebody be interested in following protocol? There's virtually no legal liability. The court system can take 25 years to legislate, and nobody's going to complain. And why would you learn? I mean, it's not just protocols, right? We have done work on training nurses in, checklists, this, that, and the other. There is no demand for any of that. So long as you're spending money, well, fine, you're happy to do it. The minute you withdraw, the demand collapses. Things go back to where they were.
Nachiket, this is almost, it sounds like this requires, sad to say, a generational change, right? You start with training people way earlier on, maybe even before medical school and nursing school.
I don't think it's a training problem, sir. I think doctors are the smartest people in India. You can't become a doctor unless you're God's gift to mankind. So I don't think it's a matter of training. It's not a matter of they don't know how to use technology. I'm sure they're all using the latest possible smartphones, right? I think the issue is there is no incentive to do it, right? The same doctor, you transport him to the UK NHS, he follows protocol to the T. You send him to do the USMLE and you plonk him inside one of the Kaiser hospitals, or, he's the perfect T follower. You see that in your Harvard, medical school. These are the same doctors that were trained right here, right? I think it's a matter of, do I really feel the need to do it? And I don't think we can take the culture approach. That's 100 years. We have to move faster. And I think a lot of countries realize, including Thailand, which had a very good performance culture underneath, that without a outcome-based payment to the system, not to the individual, to the system was never going to put the right incentive on the frontline provider.
But Nachiket, can I ask? I'm not sure if you think performance pay is the answer. So
Performance pay to the system, not to the individual, to the entire hospital,
outcome-based, yes,
to the entire district.
Yeah.
Not to the individual. Individual still continues to be salaried. The problem is not the individual. The system doesn't demand performance from that person, because the system gets compensated no matter what.
So there's a bunch of different directions, and I'm looking at the time. We have 13 minutes. So let's see, one sec. Sonia, there are a couple of questions that were targeted towards you in the chat. One was, asking, maybe you can respond to this in the chat. What are the data that are available for domestic violence and so on and so forth.
Yeah.
And then people want to pick up on, there are two questions here to pick up on this issue of how does one make health a voting issue? To the extent that you agree with my, quick and dirty characterization that it is not a voting issue currently, at least in India. How does one make it? And you made an offhand comment that it's possible to do. And I'm all ears, and I made a note for the Lancet Commission to hound you until you tell us how to do it.
So I think the way to do it, not just for health, but for other things, is provide information and a sort of community level force. So provide information through communities, for communities. So I really believe in communities also for actually generating incentives. So I think that the community should work together to demand healthcare, to create I think things like appreciation. But where I really want to go, I've been waiting to say, is I want to say more broadly that I think there is huge potential in paying nurses more, training them more, and creating this huge new workforce of community health workers that are actually don't need a lot of training, but are quite well paid so that they are committed to their jobs. They have long tenure, they learn, and that learning stays, because if they're underpaid, there'll be high turnover. And they could take care of so much. So I don't just mean maternal and child health, which clearly just means quite lightly trained.
So you alluded in your earlier comments, Sonia, and I made a note when I was summarizing after you had said, to some work that you had done in Brazil. And my impression is that, I've been through, I must have been through, 10 to 15 favelas in Rio and Sao Paulo and other places with the community health worker in the context of programs like Bolsa Familia and so on, and the ones that preceded those. And they were just extraordinary. Now I'm an observer in the scene. I'm not doing health research, but can you comment on that and the learnings that there might be for India and places like that, or South Asia in general?
Yeah, so what I've understood about Brazil is that they, like Colombia as well, after they returned to democracy, which was in 1988, they wrote a new constitution, and in that they constitutionalized the right to health. And the fact that it was new mattered. I think there was a real enthusiasm to create a society, also a health system that served everybody. So they really went for universal health coverage, and they expanded the number of effectively GP clinics or primary care units that they had massively, like many, many fold. So they reached every corner, every village. And these community health clinics had a very high ratio, I think the highest in the world, like much higher than, say, in Mexico, of preventive outreach workers relative to nurses. And there was actually a decline. When these primary health clinics were open, there was a decline in the number of specialists, but still health outcomes improved. So it's an example not just of expansion, which maybe not everybody can afford, but an example of restructuring. that there was a small decline in the number of hospital beds, a significant decline in the number of specialists like gynecologists and pediatricians, and instead a major increase in essentially trained nurses. And the thing I wanted to emphasize was the outreach workers. So these outreach workers would go to homes and give people information on, say, sanitation and boiling water. And we know from history that this makes a huge difference. And that sort of outreach could also address depression and violence.
So let me thank you, Sonia. So Nachiketa and Manoj, can you comment on this role of community health workers or skilled personnel other than doctors and surgeons, if you will, and the role in the health sector? And one of the questions privately to me is, can somebody also address the issue of to what extent can handheld technology play a role in this? Or is it sort of a fool's errand to pin one's hopes on it to any substantive degree? So Manoj and Nachiketa, in any order, whoever wants to go first.
I don't know much about handheld technology. I think Nachiket probably would know more, so I'll let him comment. My own experiences with seeing broad-scale adoption of new technology in India has been fairly dismal. Quickly on the community health part, I think this idea behind two parts. One is task shifting, the idea that there are key things that well-trained frontline workers can do better than doctors with 10 years of education has a lot of potential. And that's definitely something that is worth keeping in mind. It's also the downside, however, has been that in some countries, in India in particular, we've taken our ASHA workers, Anganwadi workers, and given them 50,000 responsibilities without trying to understand how much they can do without more training or more resources. So on one hand, I do agree that task shifting has a lot of promise, but I also think that our governments tend to overburden the frontline workers with more and more responsibilities from every new program that comes in. That's one major challenge. To the extent that incentives have worked in this group, we have seen a number of papers now that have tried to give targeted performance incentives and find some improvements. But I want to caution us to not treat them as if they are an infinite resource who have plenty of time in the day to do more and more. So let me stop there in interest of time.
Nachiketa?
I mean, my perspective is a little bit different. I do believe we have to look at the whole system. I don't think we can privilege a certain component of it. I mean, I just finished some work for the Chhattisgarh government. My request to the government was build more hospitals, because maternal mortality now is at a point in India, which is very different from what it was 30 years ago. You need emergency care availability. Margaret Crook's Quality Commission makes the point that you can't, and we did this Better Birth Checklist work where we executed perfectly what was supposed to be done at the PHC. And yet there was no impact on mortality, right? So it was not an execution issue. It's the underlying design was flawed. Now, the mental model that I have in my mind, is what I contrast jellyfish versus the barbell. What we have in mind is a jellyfish, where there is a hospital, and then there is this long tentacle of the ASHA worker, under-trained, under-equipped, underpaid, doing light things. I don't think that's the modern conception of health systems. The modern conception is a BART, in which there is a strong Costa Rica style, Brazil style family health team. US, of course, can afford to have patient-centered medical homes. But with the way, Dr. Bhalotra is saying, with training, with handheld devices, with point of care, I worry, for example, about not making ultrasound more easily available. Today, in the world, it is replacing the stethoscope, the point of care ultrasound. Now, we need to fix the problem not by taking away an important diagnostic tool, but by understanding why are these systems not responding to simple directives and simple controls. Why is it in their interest to be in the shadow and make some money on the side than to do the things that they need to do? So I would, feel that we have to, and the good thing about India, while there are many challenges, unlike some of the poorer countries, we are spending enough money in aggregate government plus people of India, even in a state like Bihar, to deliver good healthcare. We're just spending it very badly. And that itself offers an opportunity. It's not the perfect solution, because ideally you want that money to come in some pooled manner. But that does present us an opportunity. If we can do something interesting and build these interesting barbells, I think we can make a lot more progress.
So it's a familiar, those in the audience who've been involved in policy discussions, it's a familiar and productive tension, right? Which is, do you take a smaller piece of the big tapestry and try to optimize it better, or do you focus the bulk of your attention on system design issues? And obviously, it's not one or the other; it's a bit of both. So here you see, Sonia making a pretty passionate plug even in the chat for if we should look at the community health workers and push forward on that, almost as a modular approach to improving health systems. As I understand her advocacy, regardless of what else is going on in the rest of the system, and Nachiket's saying that the primacy of attention, especially in India or South Asia, should be at the system level design, because some of these interventions might even backfire, as well intentioned as they are. I don't propose to resolve this tension, but I'm going to just take the prerogative of the chair and try to wrap up. What I'd like to do is go ask each panelist to make a 30-second comment on anything, maybe a wish list of one thing they'd like to see happen, and then we can just wrap. In no particular order. Who wants to go? Manoj, you're on the top left of my Zoom screen, so go for it.
Super. 30-second top of my wish list right now would be to try and think of strategies to improve adherence to guidelines and evidence, more than guidelines. Basically, that will require changing the culture of how providers learn and adopt these new guidelines or new evidence into their own practice. And doing that is going to be extremely hard, but I think is a lesson we've learned in the last couple of years is primary. So,
okay, Sonia, thank you, Manoj.
You're on mute.
Sorry. I might first quickly say what I said in chat, which is that this proposition of expanding the workforce of community health workers, not as they are, but with a bit more training, better salaries, and hugely more numbers, so they're not overtasked, would also transform jobs for women at the community level. So women don't want to migrate, but close to home, they'd have skilled jobs. And all those issues of trust and friendship and everything should help with more sensitive health issues, including reproductive issues, domestic violence, and depression. And can I also just say that I think it's important to pitch for systematic data collection with administrative data available for research. The reason we know much more about, say, Brazil or Colombia is that they release administrative data.
Thank you, Sonia, on both points. Nachiket, last 30 seconds.
Yeah, I mean, my plug would be really to, I'm not saying we should not look at individual ideas, we should, but, I think it's the risk to go from that individual finding to policy too quickly, because that can produce a lot of damage. You have to integrate it back into understanding. We know, for example, to take the work that Manoj and Jishnu have been involved in, that government doctors who practice outside do a better job than when they are in the government facility. The policy implication of that cannot be fee-for-service markets should be the way to deliver healthcare. That's just too quick a jump into policy. It would damage the system. That insight is valuable, but it doesn't produce the policy outcome. So I would say we have to go back always to systems. It's not, I don't agree that it's a choice between this or that. I think signal extraction is important from RCTs, but once the signal is extracted, we need to integrate it back into the bigger picture. Otherwise, we could end up doing a lot of damage with individual ideas.
Okay, please join me in thanking. Just an extraordinary conversation. This could have gone on for at least another half hour, though we would have Zoom fatigue. Sonia, thank you again for taking time out of your vacation. Nachiket, thanks for joining us. Ever very thoughtful. And Manoj, it's so lovely to see you on the screen. And all the best to everybody. And do join us for the third of this series in a few weeks, which Salman had advertised earlier. Have a good rest of the day, evening, wherever you are. And thank you again.
Thank you all.